culture instruments, which are very important, the gram stain sink. The microscope for reviewing gram stains would be in that space between the sink and the hood. Everything there very conveniently located. The other photograph is looking behind where I was standing when I took the first photograph. And in that view, you can see the automated culture media inoculator that I'll have a few words to say about in the next slide. And you see our incubators, 2 incubators side by side on the back wall of the incoming cell. Again, everything within a few steps of where the microbiology incoming technologists would be performing their work. Now, I mentioned the automated culture plate inoculator. This was another of the recommendations from Guidon that we incorporate some additional automation to our laboratory to try and improve the flow of work and eliminate errors in our laboratory. When it comes down to it, the goal of a microbiology culture, besides detecting that there are organisms present in the specimen, is to furnish well-isolated colonies on the culture plate so that additional testing can be begun immediately. The photos on this slide illustrate how much better a job that the automated culture medium inoculator does than a human. The culture plate in the upper left-hand photo show the same growth medium. In one case, a urine specimen, a positive urine culture specimen, has been inoculated manually by a person, and then immediately next to it on the right side of that first photo is the same specimen inoculated to the same culture medium, but using the automated inoculator. And I think even a non-microbiologist, in comparing those two culture plates, can see that there are many, many more well-isolated colonies on the automated inoculated plate than on the manually inoculated plate. The other photograph shows a similar comparison using a different culture medium, but again, the results are the same. The manually inoculated plate has confluent growth of the organism from that same urine specimen. However, the plate that was inoculated in an automatic fashion has many, many more well-isolated colonies. And I emphasize the well-isolated colonies because that's what we need to have to work with so that when we set up our identification and our antimicrobial susceptibility test, we know we are dealing with a pure culture. Each isolated colony on these plates began as one cell, and then through multiplication, that one cell results in the presence of billions of cells that constitute the colony. So having a single colony to work with while we set up identification and susceptibility tests tells us that we are using a pure culture. So if we were to compare what would be the outcome of these two cultures, the one inoculated manually versus the one inoculated with the automated instrument, I estimate that we would not have been able to use the manually inoculated plates as they are because their growth is just too heavy, the colonies are not isolated, and we would have had to spend another 18 hours doing a second culture from those primary culture plates in order to have isolated colonies to set up the identification and susceptibility test. That is a step that would not have been necessary with the automated culture plate, automated inoculated culture plate. So the net effect would be a savings of at least 18 hours in having results on the patient's medical record from the automated culture plate versus the manually inoculated culture plate. So my final slide is the summary slide. While our lean migration is still in progress, the lean-based reorganization of our laboratory has already eliminated a great deal of wasted time and effort. And that wasted time and effort, I think, is best illustrated in the traditional versus the lean scenarios that I described a few slides ago, where we can save as many as 30 hours, more than a day, in time to report final results to the physician. The changes to our laboratory are being achieved without increasing our workspace nor the number of people on our staff. With the assistance of our guide-on consultant, we were able to come up with a plan that actually is saving us laboratory space. We are not going to need as much space as we used to under the traditional approach to microbiology. And we were able to adjust the work schedules of our existing staff so that we could have coverage around the clock with skilled microbiologists who are able to begin the work on cultures no matter what time or day of day the colonies are ready for further work. Most importantly, the clinical utility of our test results are being improved because we are now, with this new approach, less prone to making human errors because of our standardized processes as we perform our microbiology testing. And they are available on a more timely basis so that patient management changes based on the microbiology test results can be made in many instances a day or two earlier than they would have been made using the traditional laboratory approach for microbiology testing. With that, I will turn the microphone back over to Melissa for the question and answer session.
Thank you very much, Joe. It's now time for our question and answer session. As a reminder, to participate in the Q&A, just type your question into the Ask the Question text area in the bottom corner of your screen and click the Submit button. Okay, the first question that has come in. How did you determine which area of your lab to do the initial assessment?
Well, that's an excellent question, Melissa. The clinical laboratory in a hospital is more than the microbiology laboratory, as I think most of the audience realizes. There are sections devoted to chemistry testing, sections devoted to hematology. Many hospital laboratories also have a blood bank in addition to the microbiology section. In most lean evaluations that have taken place in hospital laboratories up to now, the focus has been on the more automated laboratories like chemistry and hematology, and very little attention has been paid to microbiology because it's such a different testing environment. As I became more and more familiar with lean principles, and particularly after our visit from Guidon to aid us in considering a lean evaluation, I realized that there were many, many opportunities that we could take advantage of in our microbiology laboratory and perhaps set a precedent that other microbiology laboratories in other hospitals that have microbiology sections might learn from our experience and decide that they, too, would like to become a leaner operation than they are now.
Right. Thank you, Joe. The next question is, by reducing the turnaround time for inpatients, do you have a sense of the potential impact to length of stay? And is there any analysis of how often there is a linkage between the two?
Yeah, another excellent question. There is definitely, if I can tackle the second one first, there is definitely a linkage between how long microbiology culture results take and how long a patient has to stay in the hospital. The most important piece of information the microbiology lab provides the clinician when a patient has a bacterial infection is the antibiotic susceptibility result. With those results, we are telling the physician which antibiotics of the many that are available are likely to be most effective in treating the patient's infection. And since many of those antibiotics are available in an oral formulation, it then becomes possible for a patient to be discharged from the hospital environment where they may have been receiving intravenous antibiotics